So hello everybody. Today we are going to see about the peptic ulcer disease, a detailed video regarding peptic ulcer. So first of all, we will start with what is the meaning of peptic ulcer. So it is usually an eroded lesion which is either in the esophageal, gastric or the duodenal mucosa, and that results from action of gastric secretions, and typically it is because of the H. pylori inflammation. Now, in normal cases, the gastric and duodenal mucosa is protected from the digestive actions of acid and pepsin, and that is due to secretion of mucus, production of bicarbonate, the removal of excess acid by normal blood flow, and with the rapid renewal and repair of epithelial cell injury. Peptic ulcer, it refers to an ulcer that occurs as a result when this defense mechanisms they fail, and that is because of, or you can say in other words, that is because of the breakdown of this defense mechanisms. Typically, for peptic ulcer to develop, it is important that one or more of the mechanisms might be malfunctioning, and it shows the evidence of chronic inflammation and repair processes surrounding the lesion. So this is about what is peptic ulcer and how it develops. If we see about the etiopathogenesis, it develops either because there is fallen mucosal defenses, there is decrease in the mucosal blood flow, delayed gastric emptying, impaired epithelial restitution, or impaired prostaglandin synthesis. Etiological factors, mostly it is H. pylori infection, because the host factors as well as the variations among the H. pylori strains that determine the outcome or the clinical outcome. So this is one of the most common cause, that is H. pylori infection, very common cause for the development of peptic ulcer. And if we see about the structure of H. pylori, it is usually a gram-negative bacteria, rod-like structure, and it has flagellas. Transmission of it is through fecal-oral route, and it secretes urease. Now this urease that has the capacity to convert urea to ammonia. How it survives? It survives by producing alkaline environment in the stomach, and that helps it to survive, and that is with the production of ammonia that results in the development of alkaline environment. Almost all the type of duodenal and two-thirds of the gastric ulcer patients, they are affected with H. pylori infection. Also, it can be considered as a class 1 carcinogen responsible for producing gastric cancer. How this causes infestation? That is, it moves in the mucin layer via flagella. It has urease which produces ammonia from the endogenous urea, and it buffers gastric acid in the immediate vicinity of the organism. So it expresses of bacterial adhesins that enhances bacterial adherence to the foveolar cells, as with the expression of bacterial toxin, and that is CAGA, that is cytotoxin associated gene protein, and the second is vacuolating cytotoxin gene protein. Now both of these proteins or the bacterial toxin will block the T cell response, and it induces apoptosis. Along with the other host factors, it will cause the increased expression of pro-inflammatory cytokines like tumor necrosis factor, interleukins, or decrease in the anti-inflammatory cytokines like interleukin 10, and that leads to situations like pangastritis, atrophy, and gastric cancer. So this being one of the etiological factor for peptic ulcer, and the most common, that is H. pylori. How it develops? It enters into the layer of the stomach where the urease converts urea to ammonia, and in the immediate vicinity of the organism it creates an alkaline environment which helps it to survive, and slowly and gradually it causes the decrease in the expression of the different variants, and the pro-inflammatory cytokines and anti-inflammatory cytokines, all of this comes into action, and slowly and gradually it leads to the development of pangastritis, atrophy, and gastric cancer. That is because it eats up the layers of the stomach, surrounding it. So this is the common cause. Second, certain other causes. The first one, that is Zollinger-Ellison syndrome, Separately also it can be asked as a short note. What it causes? It causes an uncontrolled release of gastrin by tumor and resulting massive acid production. Second is chronic non-steroidal anti-inflammatory drugs use. Now this causes prostaglandin synthesis suppression, and which is usually necessary for the mucosal protection, and that leads to toxic injury to epithelium as well as the endothelium. Certain drugs like cocaine, it also reduces the blood flow. Cigarette smoking, again, it hinders the blood flow and healing process. Stress, again, a common factor which increases gastric acid secretion, and genetic factors. People usually with blood group O, this are more prone for the development of peptic ulcer. Now, this is based on data, and viral infections like certain infections like cytomegalovirus and herpes simplex virus had as an etiological factor for the development of peptic ulcer. Pathogenesis, there are different mechanisms which are involved for the development of either the gastric or the duodenal ulcer. If we talk about the duodenal ulcer, what happens is the mucosal digestion, it occurs because of hyperacidity and damage to mucosal barrier. So these are the two keywords that leads to the development of duodenal ulcer. One is hyperacidity, second is damage to mucosal barrier, and this is because there is increase in the secretion of gastric acid at the night, and that is under the influence of a nerve, that is vagus nerve, and this nerves get stimulated, so the rapid emptying of stomach food will take place, which normally neutralizes the gastric acid into small intestine. It starts acting on duodenal mucosa. Second is how about the gastric ulcer to develop. Now the key notes here is impaired mucosal defenses, impaired gastric mucosal defense, and that is against the action of acid and pepsin secretion. So this is the normal defense mechanism, that is we have a mucus layer and which is with bicarbonate and surface epithelium. Mucin, which is secreted by the cells, also has a resistant property and which is enhanced with the secretion of bicarbonates and sodiums with the epithelial cells, and that neutralizes the hydrochloric acid. Second is the surface epithelium. It again forms a second line of defense, which is an adequate blood supply to the mucosa is important for maintaining all of these normal functions. Ulcer develops because either or there is defect or failure of this defensive mechanism, and that leads to the colonization of Helicobacter pylori. Also, if one is taking excessive of spicy food or alcohols, it can lead to trauma. Smoking again will, as we have talked earlier, that it will hinder the blood flow, it will impair healing. Excess of acid or hyperacidity, it again causes the increased serum gastrin level, and incompetence of the pyloric sphincter, it leads to bile reflux, and this bile it causes or damage to the mucosal barrier. And not only this, the cigarette smoking also it hinders or it affects the resting tone of the sphincter. So if we see about the peptic ulcer diseases, there are certain factors that protect against acidity, and there are certain factors that increases the acid secretion. So the whole story is maintaining a balance between both of these things. So the certain factors that protect against acidity are like mucus, bicarbonate layer, blood flow, cell renewal, prostaglandins, tight junctions between the epithelium. And if we see about the factors that increases the acid secretion, it is like acid, pepsin, bile acids, non-steroidal anti-inflammatory drugs, H. pylori, and alcohol. So the whole story or the whole pathogenesis is because of the imbalance that develops between the layers or the factors that protect and the factors that cause an increase in acid secretions. Clinically, the patient will be having abdominal pain, which is usually localized to epigastrium, and it shows relationship with food and periodicity, so as the gastric or the duodenal ulcer. Pain, patient can sharply point it with one finger, and so it is called as the pointing sign. Burning character, hunger pain, which is usually that occurs on empty stomach and it is relieved by food or taking antacids. Also, there are night pains which wake the patients from sleep. It is relieved with food, milk, or antacid. Pain relief is by eating something, by with belching or vomiting. In some or most of the gastric ulcer patients, food precipitates the pain. Periodicity also is seen, that is, the patient is perfectly well in between the episodes, and you can say it as the type of episodic pain. These are the main clinical features. Along with it, there are other symptoms like water brush, heartburn, loss of appetite, vomiting, nausea, fullness, bloating, and dyspepsia. Rarely, the patient may present with the anemia of chronic blood loss, abrupt hematemesis, acute perforation, or gastric outlet obstruction. Now, this typically shows the difference between the duodenal and the gastric ulcer. You can have a look up to it by your own. I'll just take a screenshot. Fine. Investigations, if we see, usually the first line of investigation along with the diagnostic test is stool examination, that is to be seen for fecal occult blood, CBC to rule out all the diseases in blood cells or decrease in blood cell. Diagnostic test first is endoscopy, that is to visualize the ulcer crater. Ability to take tissue biopsy to rule out cancer and to diagnose H. pylori. Barium swallow X-ray, which again will visualize the upper GI tract, and a urea breath test, that is to detect H. pylori. In all the patients, those who are showing symptoms like dysphagia, weight loss, vomiting, anorexia, and hematemesis or melena, endoscopy is required. Complications, mainly it shows hemorrhage, and that is because the blood vessels are damaged and it erodes into the muscles of stomach or duodenal wall. There will be either coffee ground vomitus or occult blood in stool. Perforation, that is the second complication, that is the ulcer erodes through the entire wall. Bacteria and the partially digested food can spill into the peritoneum and cause the third complication, that is peritonitis. Management in case of peptic ulcer is divided into four subsections. The first one, that is lifestyle modification. Second is the hyposecretory drug therapy. Third being the H. pylori eradication therapy, and the fourth is surgery. So if we see about the lifestyle modification, advise the patient discontinue the drugs, that is non-steroidal anti-inflammatory drugs. Smoking and alcohol should be stopped, and stress should be reduced. Hyposecretory drug therapy, it involves proton pump inhibitors, H2 receptor antagonist, antacid, prostaglandin analogs, and the mucosal barrier fortifiers. Now, this is the function that it performs. Okay. H. pylori eradication therapy, triple therapy is usually suggested or is done. There is a proton pump inhibitor given along with two antibiotics. And surgery, being the last resort, it is indicated when medical treatment seems to fail, there is development of complications, there is very high level of gastric secretion, and the patient is showing both the gastric as well as the duodenal ulcer. And the main principle behind performing the surgery here is to reduce the acid and pepsin secretion. Types, if we see, the first type of the surgical procedure that needs to be done is gastroenterostomy, which will create a passage between the body of stomach to small intestine, and that will allow the regurgitation of duodenal content into the stomach and keep the acid away from ulcerated areas. Second is vagotomy. It will curve the vagus nerves, cut the vagus nerve, sorry. So there will be no more stimulation, and it eliminates the acid secretion stimuli. Pyloroplasty, the third form, which will widen the pylorus, and it will guarantee this empty stomach, it will guarantee the stomach emptying without vagus nerve stimulation. Enterectomy or subtotal gastrectomy, that is the lower half of the stomach which makes most of the acid, and it is removed. So there will be decrease in acid production. Also in subtotal gastrectomy, there is removal of half or two-thirds of the stomach, and remainder is attached to the rest of the portion. And the last, that is Billroth 1 anastomosis, where the distal portion of the stomach is removed and the remainder is again anastomosed to the duodenum. So this is in short video regarding peptic ulcer disease. Hope it was useful to all of you. Thank you for watching.